Hello again, Wendy.
Oh, okay. I will open this window again.
The mic should be showing up here too, I think. Yeah. There you go. I thought he was, but we appear to have lost Mike. All right, we might as well start because we don't have a lot of time. So we're going to introduce ourselves. I think we lost Dr. Payne in between moving from the stage over to the session now. But welcome everybody. I'm really happy that those of we here in New Brunswick can join you in this virtual Ontario Amputation Conference. I'm Colleen O'Connell. I'm a rehabilitation physician at the Stan Cassidy Centre for Rehabilitation in Fredericton, New Brunswick. And my colleague, Wendy Hill, is a research occupational therapist. And we both are at the Atlantic Clinic for Upper Limb Prosthetics here in Fredericton, associated with University of New Brunswick. And we're going to be talking to you. We're going to use one of our actual cases, Adam, who's given us full permission to show you his pictures and his videos, and you'll see him. And as an introduction to some of the novel approaches that we're using and exploring for prosthetic control and for phantom pain management. And these are kind of intricately linked together. So I'll introduce you now to Adam. So Adam is a young man, and young becomes relative the older I get. But he's out, he's a fisherman, and he was out quite a few miles offshore at sea when his left arm got caught in a baiter, and he had an immediate amputation at wrist disarticulation level. He kept his cool. He put his hand in a bucket of frozen fish bait, and the 6-hour sailing back to the mainland, and was into the OR with surgeons who reattached his left hand. So this occurred on Valentine's Day in 2018. However, although the reattached hand was viable, it was really quite non-functional. He had some flickers of movement in his wrist flexors and finger flexors, but unable to make any type of functional grip. And therefore, after consultation and evaluation, we moved forward with an elective amputation almost exactly a year to the date that he initially lost his hand. So 2 years in a row, Valentine's Day, again, lost his hand. Now, the interesting thing about Adam is that in, not to say he's accident prone, but in almost 20 years previous to that, he'd had a sawmill accident where he lacerated the volar surface of his dominant right forearm, rendering his right hand weak and with contractures. And so he had already switched to becoming left-hand user, and relied on his left hand for most manual tasks. So now he is now having lost his left hand and going back to using his right hand. So some of the issues with Adam, he underwent then the elective amputation at the distal forearm in February of 2019. And he has had some persistent phantom pain as well as some neuroma pain. And he's got, as I mentioned, the issues with the decreased function and strength in his right hand. But Adam has a lot of goals, and he's super motivated, and he's a perfect person for presenting to all of you some of the strategies we've used.
Okay, Adam did have a lot of goals, and like many people, was most interested in being able to return to his previous job duties. That's still in question at the moment, but rightfully so, he wanted to be able to try to get back to fishing. Cooking was also very important to him as a gourmet home chef. He camps, has an RV. He wanted to be able to repair his vehicle and his ATV at home, and was very concerned about being able to do his own self-care. So those are his main goals. And with goals like that in mind, we often compare the need for multiple prosthetic devices to choosing the proper tool for the job, or or using proper footwear, depending on the occasion that you're going to be participating in. So we don't wear dance shoes on a construction site, and it's important to have proper footwear that's appropriate for the job. In his case, we had the option of looking at multiple devices because funding allowed for that, being a work-related accident. And so he did have a body-powered device made and had an activity-specific prosthesis. And a powered prosthesis was extremely important to him because of the decreased strength in his right hand. So durability and dexterity were the biggest features that he was looking for in a prosthetic hand. So conventional or traditional myoelectric hands only offer one degree of freedom. They open and close in a tripod grip. So we were looking at a multi-articulating hand in his case, and in many cases, to give us the option of multiple grip patterns, the increased dexterity, and the conforming grip that is so important to be able to hold odd shapes with a secure grip. But one of the issues that we always face with these advanced prosthetic hands is how do we control them? When you're controlling multiple grips, you often need to do that with using mode switches, and it can be cognitively a lot of effort to learn how to control these things. With direct control, in order to access the different grips, we use muscles in different ways. We have to use mode switches or external buttons or non-intuitive controls. With pattern recognition, which is becoming more and more common, it makes that process a lot more intuitive. It takes the information from all of the muscles around the forearm and translates those into patterns that are recognized and mapped to specific prosthetic hand functions. So you can see in this top video what it means to have control, direct control, using direct control with the wrist flexors and the extensors. They're being used in this video to operate open and close, hand open and close, and a co-contraction is being used to switch modes. Let me stop that one. In the bottom video, you can see that the information from all of the forearm muscles is being used, and each distinct pattern is being mapped to a specific function of the prosthetic hand. This allows the user to use the residual muscles in the way they are intended to be used to do things like wrist rotation, hand open and close, and different types of pinches like lateral grip or a tripod pinch. So it allows the user to do this in a more natural way. So in this video, you'll see Adam directly switching to the various grips that he has programmed into his hand. So I'll play this for you.
Yeah, we task a hand here in a relaxed position. Now we're going to go to key grip. Now we're going to get a hold of this measuring cup with the key grip. We'll find it on the counter, pull it out. Hold it real good. Bring it over here to the glass. Pour the water into the glass. Put our king back down. Now we have water in our glass. Now we'll go to the power grip to grab a hold of the glass. Power grip. Grab our glass. Have ourselves a drink. Now we get something smaller here. We've got a pill bottle. So we'll switch over to tripod grip. We'll grab pill bottle with our tripod grip. No problem. Put it back down. Then rotate it back up. Then we can do the flexi tool grip if we'd like. flexi tool. I'd show you picking up a knife, but I only got one knife. Okay, thank you. Bye. There we go. Tasking.
So although pattern recognition offers more intuitive control of a prosthetic hand, it does require extensive training to get to the point of using it functionally the way you saw Adam doing that in the last video. We spend hours training in a virtual environment in the clinic before fitting happens, and then many, many more hours when the final device is ready. One part of the training process that's been very difficult is the lack of at-home training tools. And we've been very fortunate here at UNB that we have a group of just this past year, we've had a group of senior undergrad engineering students working on a VR training tool that can be used at home. So using commercially available products, they've developed this VR training suite of activities that will help to train pattern recognition. So I'll show you what some of these activities look like. We have a virtual box and blocks test that can be used for that skills and drills of moving objects from one place to another. Oops, sorry about that. This is a claw game that's activated by moving a bunch of levers and buttons on a table. So he's using open and close of his hand and able to move his wrist and pick up these blocks and move them around the environment. And then there's a tomato smash game that I want to be able to show you, where you pick up a hammer and you need to maintain a grip on that hammer and move it in space. So you're able to need to be able to keep the muscles quiet while you're smashing tomatoes that come down a conveyor belt. All very fun and able to be used at home, which is great. So here's a small snippet of Adam testing out this system for us, which he very much enjoyed and said that he would be happy to do this all day long at home. So now Colleen will talk a little bit about phantom pain.
So part of the reason for bringing you through what we're demonstrating in terms of using pattern recognition and some of the strategies for practice and training in pattern recognition actually then also feed back into some of our potential treatment strategies for phantom pain. So there's a little bit of almost like a circular type of one can help the other argument. If we look at Wendy, advance a slide, please.
Oh, sorry.
So if we look at the various options for treating phantom pain, we really don't have a lot of great options that have any robust background of evidence. Even the pharmacologic strategies and the surgical treatments that are typically used, medications such as gabapentin or your opioids or their NMD receptor antagonists like ketamine, don't have strong evidence, and they really are only giving short-term benefit. The surgical indications or surgical options such as your spinal cord stimulators and deep brain stimulators aren't really indicated specifically for phantom limb pain. And so some of the options that have been a lot more accessible with lower adverse events are those non-pharmacologic cognitive behavioral therapies, mirror therapy, and visual imagery. And Wendy's going to present to you how a number of these now are incorporated along with pattern recognition towards treating phantom pain.
So mirror therapy is one of the most used treatments that we use for phantom pain with our patients. And Adam actually responded really well to using mirror therapy with his phantom thumb in particular. He really liked the fact that in the mirror he could move his phantom thumb to a greater range of motion than he was able to do without looking in the mirror, and at the same speed as what he can do with his actual thumb. One of the disadvantages in his case is that he doesn't have full extension of the fingers in his right hand, and so that limits the range of motion of what he can get in the mirror with his phantom hand. Fortunately, we have a system available at our clinic that we have, because we've been involved in a study since 2018, originating in Sweden, with this system called Neuromodus by a company called Integrum. This system uses pattern recognition to control the phantom limb in a VR environment. And I'll show you a little bit about what the study involved. The study was called Phantom Motor Execution as a Treatment for Phantom Limb Pain. This was a randomized control study that looked at 2 different treatment strategies, both using VR and pattern recognition. And the options were phantom motor execution, which is the intentional movement of the muscles of the residual limb, and phantom motor imagery, where the muscles are kept quiet while the person imagined their phantom limb moving in distinct patterns along with an augmented limb on the screen. So we've been using this clinically since the study has now been completed, but you can see in this video what the training looks like when you're going through. So there's electrodes placed on the surface of the skin, and we choose which movements he's going to train the system to do.
It's kind of your cue to not keep your hand out straight when you're doing the rest.
I cue him through the process. I'm like his exercise coach.
Right.
There needs to be a lot of communication as we're going through this process, so I'm sure that he's doing it the way I'm intending for him to do it. So I'll turn that off, and then I'll show you what it looks like when he's actually manipulating the limb on the screen after he's finished the training process. Oops, I'm doing the wrong one.
So what are you doing now? Bring your finger in. And try opening the whole hand. Oh, you've got the thumb. You had your thumb halfway up. Great. And close your hand.
So you see how he's able to manipulate the hand in a way that really is not possible for him to do in the mirror, but also not possible for him to do with a prosthetic hand.
How does it feel? Do you feel like that's actually your phantom moving? You have to do this for a while before you notice that.
So you'll notice he said that no, it did not feel like his phantom hand. And I've had different experiences with different people using this system. He did not relate to the limb on the screen more because it was not moving at the same speed that he could move his phantom limb. So there's some room for improvement in a lot of these VR strategies. But for him, I liked the ability to be able to try the different, to go from mirror therapy to using this system and see the differences and what he was capable of doing. And then the other advantage to this system is that it's able to put an augmented limb on the screen so that it makes it look like you're sitting in a mirror. And for some patients, especially for those people that are missing both limbs, upper or lower, because the system works just as well for lower limb amputees, the ability for them to be able to experience mirror therapy in this way is a great advantage. And that is the end of our presentation. So if there are any questions, we're happy to answer.
Fantastic. Clap, clap, clap. Thank you, guys. There are questions just in the we probably have 3 minutes. I'm going to combine the top two. How do you measure phantom limb pain, and how much is sort of significant with that, and what are the duration of benefits? What's the durability?
The durability of what?
Of the improvement or the decrease in phantom limb pain.
Well, from the study that's just being completed, and more of that will be published in the coming months and years. But from the pilot study, there was improvement in phantom pain, a significant improvement in phantom pain that was lasting beyond 6 months after the study. So it has been, it doesn't necessarily eliminate phantom pain, but it's certainly making a significant reduction, and allowing those people who weren't functioning or weren't sleeping properly, it's helping with sleep. That's one of the main benefits.
Okay, and are you using a, sorry, Colleen, go ahead.
Well, I was just going to, in terms of a measurement tool, I think there are a variety of tools, maybe Wendy, just the tools that we used in the study. In day-to-day clinical practice, I just typically use a numeric rating scale, 0 to 10, and something like a pain interference scale, like you would use on a brief pain inventory. But for the study itself, Wendy, were there other tools?
There are a ton, and I'm not sure I could name them all at this moment, but there are a ton of outcome measures that are being tracked through that study. Including just the basic pain measurement, but also a lot of the quality of life assessments as well.
Yeah, those are crucial. Final question, Amanda, our OT in London, great presentation. And do you have any resources for mirror therapy? I thought it was interesting that your guy was challenged with pre-existing impairments on his bedside. That's tough.
As far as resources go, I do have some protocols that have been developed at different places, some of them through the military hospitals, I think, in the US. But really, I just go based on what the clinical presentation is and what their needs are. So I tend to start where their phantom is and kind of work through. I'm finding myself, I've provided people with all kinds of resources and take-home programs, and it doesn't get done. That people like have great intentions to go out and get themselves a mirror and do this work at home, and I find that they just don't do it. So clinic-based seems to be the most effective. If I can get them in the clinic on a regular basis, then we can work through some of these things together, and they're more likely to do it with me than they are on their own.
And Mike, I would just say, I think this year's CAPM&R medical student essay winner is a review of using mirror therapy for upper limb pain. And one of the strategies we've done here at our center is when they're admitted with us or they're coming as an outpatient is our therapists build the mirror box with them together. The building of the box is part of their therapy.
Wow.
That's great.
Kind of like shop.
Cool. All right, 2:30. Thanks very much, everybody. Thank you, Wendy and Colleen. And the next one is at 2:35. Back in the meeting room.
Bye.
Bye. Good job, Wendy.